This program is brought to you by Emory University.
This conference was co-hosted by the Institute for Developing Nations and the Emory College Program in Global Health, Culture, and Society, in cooperation with the Carter Center.
So in April 26th and 27th here at Emory University with the Carter Center and sponsored by the Institute for Developing Nations, we hosted a very interesting conference that linked historians, social scientists, and practitioners of public health who focus on disease eradication and elimination. So this video is partly about that conference and the different views that the participants had. The conference was called Disease Elimination and Eradication in Theory and Practice, New Directions and Multidisciplinary Collaborations. There were a lot of reasons for doing this at Emory, and the IDN was very interested in making connections between Emory University and the Carter Center, and also because Atlanta is sometimes called the crossroads of global health because of the CDC, the Rollins School of Public Health, the Task Force for Global Health, Care, and so forth. But the Carter Center itself has a focus under President Carter on disease eradication, specifically guinea worm eradication. And the former president's goal in life, he says now, is to outlive the guinea worm. Disease eradication is a kind of ultimate goal to wipe a particular human disease off the face of the earth. And we've tried to do it historically 10 times, different types of diseases, from yaws and malaria to smallpox, which is the only successful human disease that's been eradicated. So it no longer exists. And that's a wonderful human achievement that was completed around 1977. At the same time, in 1978, there was a very important conference in the history of global health called Alma Ata, which emphasized something very different than the vertical single disease eradication programs like smallpox. It emphasized primary health care, that is, the delivery of basic health services to every individual on Earth. So essentially, in the late 1970s, we had this crystallization of opposing worldviews about global health. One in which has more vertically organized programs aimed at single diseases, and another one which is more oriented towards basic health services, both preventative and curative. There's a long history of this dispute, or if you want tension, dynamic tension, in the field that used to be called tropical medicine and then was called international health, and then in the late 1990s started to be called global health. Around that same time that we were able to declare the incredible success of smallpox eradication, there had been a 20-year program, a worldwide malaria eradication program, that got abandoned. It was considered a failure. And because of that failure, I think the pendulum swung towards emphasizing child survival and primary health care. In the late 1990s, after the end of the Cold War and the beginning of a new emphasis in global health that focused on partnerships and less of an influence of the World Health Organization and more cooperation between developed and low and middle income countries, a surprising thing happened to many of us who are social scientists and historians, is that the emphasis on disease elimination and eradication kind of resurrected. And one of the most amazing things was in 2007 when Melinda Gates announced that the foundations, the Bill and Melinda Gates Foundation, was interested in setting a goal of malaria eradication, which more than 20 years before had been identified as something that really couldn't be done. And then in 2012, in London, about a dozen drug companies and international bodies like the World Bank and USAID and so forth signed something called the London Declaration about Neglected Tropical Diseases, which identified a wide variety, about 22, about 10 specific diseases for eradication or elimination. And when we count the other diseases that have been targeted, there's about 22 out there. So this is there's more money in the 21st century for global health than before, but this tension between focusing on particular diseases or strengthening health systems still exists. So that's a lengthy background, right? So, but the conference itself, we wanted to get practitioners together from the CDC and the Carter Center. People who worked on polio, people who worked on guinea worm, people who were working on river blindness and so forth, together with a group of anthropologists and historians to see if and how there was common ground. The anthropologists and historians have often been critical of the approach of disease eradication, and there hadn't been very much productive discussion across these areas or disciplines of public health and academia. So this is what we did: is we brought together historians, anthropologists, and a wide variety of practitioners, both from institutions here and representatives of nations that have high rates of these infectious diseases. The Institute for Developing Nations at Emory University helped the team design a conference that had a different structure, and it was very successful. What we did was we had invited about 9 people from outside of Emory, about 10 people from the public health communities and local African scholars who were working at Emory, and a number of Emory faculty themselves. But instead of doing a conference in which the regular boring way of everybody just kind of presenting a 20-minute or 30-minute paper in which there was little room for discussion, we had more rapid, in sequence presentations by our outside visitors, only 10 minutes each, which gave us almost an hour after each session to discuss. And it's in the discussions where the most productive interactions happen. So our 3 main foci were first about questions about priorities and evaluation, kind of big questions about disease control, which is to lower morbidity and mortality, as opposed to disease eradication, which is to globally remove the disease organism from the universe, and something in between, which is called disease elimination, which is to remove the disease or make transmission down to zero within a geographical region. There's lots of debates about that, and there's also debates about how we can measure progress and whether we can measure progress in other areas than just disease rates. There were discussions about the issues of partnerships, and the relationship to local communities became a constant theme. But the partnerships are between donors, the public health practitioners, and the local communities. And we had one session that emphasized these kinds of partnerships. And then finally, we had discussions about strategy and strategies in the future and what we can understand in terms of global health strategies in the past. I should say that in the conference, we were dealing with an area that is very contested, and sometimes people can get offended because particularly the practitioners have devoted their whole lives to these programs. And programs that we thought might take 5 years are taking more than 20 years. So being a critic or being not on board is sometimes viewed as not appreciating and not valuing the huge amount of work that has been done. So if we take, for example, just in polio in Pakistan, which still exists, we've had 200,000 workers involved in this. The scale in eradication programs is quite amazing. And I know that the people who are critical also have great admiration for the people who are doing things. And conversely, the people who are doing things understand, but don't necessarily discuss very often, the problems, the issues about discourse or hyperbole or the political issues involved in getting a disease eradication program done. So those people are not naive, and both sides have goodwill. So, and I think in the end we found a lot of areas in which we can go forward in research and in collaboration, and not confrontation. We're really grateful to the Institute of Developing Nations at Emory University for sponsoring this conference, this very productive and interesting conference on disease elimination and eradication in both theory and practice that brought together historians, anthropologists, and most importantly, disease eradication practitioners. The IDN has one of its roles of making connections between the Carter Center, a world-famous institution that has a great reputation in terms of disease eradication and elimination, and the different kinds of scholars from history, from the social sciences, from environmental sciences. The IDN has been wonderful and productive in collaborating with us, that is us, the people both from the Carter Center and Emory. And I think we've had, at least in my 35 years at Emory, one of the most interesting and productive and positive interchanges, I think largely because of the input and help of the Institute for Developing Nations.
The work that I'm doing and in the field of historical epidemiology provides an historical record of the impacts of interventions on infections and looks at both the successes and failures of past interventions to provide an empirical record that can help to inform contemporary policy making. Well, I study malarial interventions, and I think that the most important issue is at the moment the extent of the vulnerabilities that are being created by the very rapid rollout of various interventions. The historical record suggests that the long history of malarial interventions in tropical Africa is that of control and lapse, and that during times of lapse, if the control has been very good and has lasted for a few years, that populations that were once protected find themselves newly vulnerable to malarial infections, and that these infections are often severe in age cohorts that had previously had acquired immunities. And we are currently, in 2013, at a moment when global funding for the malaria campaign is in question, and where we're not replacing nets, for example, at the rates at which they need to be replaced. And so we may be on the verge of kind of a new era of vulnerability. And that I think that the importance of the historical work is that it brings this issue forward in a way that public health practitioners can take account of it, and that will perhaps be able to plan interventions in the future with some fail-safe options.
So I'm a historian, and I specifically work on the history of Africa. So from my perspective, African history and the history of medicine and health give current public health campaigns a sense of perspective, which is an intuitive part of it. The other thing that I think historians can offer to public health practitioners presently is a sense of the finely textured local detail that can influence the way that public health campaigns in either the short term or the long term play out. So there's the sense of historical perspective, but also because I have an interest in cultural history and an interest in social history, a sense of why exactly particular relationships fit together as they do, why exactly people interact with the government or with an outside body as they might. And I think also, I mean, another thing that history can offer to a public health campaign or to global eradication campaigns in particular is just a sense of how to locate, of how practitioners might locate themselves in our particular historical moment. So not to say that we have to be only attentive to what happened 50 years ago or 75 years ago, but rather also to think about what is the immediate historical context for instance, the ongoing eradication campaign in northern Nigeria or in Pakistan, or what might we need to consider if we're thinking about the implementation of other campaigns within the next 5 to 10 years. What else is going on? How do larger social or political or economic forces globally affect the way that something happens in this one small area, which is, after all, where we have to start? Well, one of the things that really strikes me is how how public health practitioners and historians or social scientists, anthropologists are interested in a lot of the same kinds of problems. Why do certain people get sick and other people don't? How do we improve people's health? How does that contribute to the overall livelihood of a region or a nation? And so, from my perspective, a really helpful research agenda or a helpful thing to figure out would be, how exactly do we as historians, who generally think in much longer time spans and have a time scale of our own production that is much longer than public health intervention might need, how do we bring those two things into line in productive ways? So how do we put together a cultural history of a particular place or a particular phenomenon that can then be useful for public health practitioners who are working in that same place or in a similar place. And I mean, one of the things that I think is really important as we're thinking about how historians or social scientists can contribute to or can interact with ongoing public health campaigns is just the ability to constantly remind ourselves and remind practitioners that one size very rarely fits all. And so if we can figure out a way to develop models for considering local idiosyncrasies alongside the much broader trends in global health, in particular methods or interventions, I think that's a really helpful place to start. And then I also think that that it would be really wonderful to work together, from my part, with somebody who's actively engaged in a public health campaign to write for a scientific audience or to collaborate to write for a humanities-based or a social science-based audience, and think about how we might build particular types of narratives that are compelling, that are useful, that are illuminating for those different audiences. And I think we really have to take advantage of the expertise of both of those groups, the expertise of both sets of people, in order to do that effectively.
Well, medical anthropologists have a long history of cooperation, collaboration, and antagonism sometimes with public health programs in general. And historically, most medical anthropologists who work on public health programs have done so from the perspective of helping to explain local culture or helping the programs themselves understand better what's going on in local communities. So that's sort of one way that anthropologists historically have contributed to public health programs. I think it's clear to everyone involved in eradication programs right now that the biggest challenges to success of those programs are not problems that a virologist or even an epidemiologist can easily deal with. The barriers to eradication that are seen in the case of polio, and the three remaining countries are Pakistan, Nigeria, and Afghanistan, are problems of really complex political situations, of violent unrest in many cases, of really complicated situations on the ground that are very difficult to maneuver. What you see in the remaining endemic countries for polio are really complex political and social factors that make the interactions between communities and these big global health programs very complex and often very difficult to negotiate for everyone involved. And I think both anthropologists and practitioners are interested in these relationships and how they work, whether for practical or academic purposes or both. Understanding them better is an important part of understanding the trajectory of eradication programs. And so I think that there are natural overlaps between the work that we do.
Global elimination and eradication efforts are profoundly historical processes, so to understand how they've operated in the past, how they might operate in the future, and what variables are important, you need a historical perspective. You also need a social science framework to interpret that evidence so that it actually makes sense, so that you know what to pay attention to from the past and you know what to take forward into the future. Historians, social scientists, anthropologists, and public health practitioners need to work on how to manage the politics of disease control programs. This is because almost 95, maybe 98% of public health programming is done technically. Almost none is done ethically, and almost none is done politically. Yet politics determine who gets what, when, and who pays. So managing that process is one of the most important factors in determining what actually happens.
We are told, and rightly so, humanity has three enemies: fever, famine, and war. And fever basically is malaria. And malaria kills over 1 million people a year, affects over 250 million people a year, is responsible for about 15% of school absenteeism in Africa. So when you fight your enemy, you don't fight half-heartedly. So we should create a meeting of minds in the global community to fight and eliminate malaria and possibly go for eradication. I was telling my friends during break that if smallpox was out there in the world today, we would still have plenty of people who would say it's not cost effective to eradicate smallpox. It's not going to work and stuff like that. And I think people of goodwill and people who have the knowledge of what has worked and what has not worked before, bringing different disciplines to align themselves towards a common goal. I think we can eliminate many of the diseases that are eligible for elimination. And my call for the scientific community is to try to understand what has failed in the past in our effort to eliminate, eradicate disease, and what has worked, and to build on those things that have worked and work towards achieving a world free of malaria, a world free of polio, guinea worm, and all the diseases that affect humanity.
Increasingly, increasingly the arguments for elimination and eradication include an economic component or an economic rationale. That is, that everybody wants to know what the return on investment is for elimination and or eradication. And sometimes that's very difficult to tell. So that's one side of the contribution. So I think contributing to the methodologies, to develop the responses to those kinds of questions from countries, from donors, from others who are philanthropists who are interested in investing in elimination eradication program. It's important for them to know what the, quote, return on investment is going to be. From the health systems side, I would say that one of the contributions that health systems folks, people like me, who look at the broader issues of health system strengthening and the ways that any disease control programs, and in this instance elimination and eradication programs, can contribute to health system strengthening, is to ask perhaps pertinent and sometimes impertinent questions about why invest in elimination and eradication when we can't even get generalized primary health care to much of the population in those endemic countries that are the most at risk for the eliminatable and eradicable diseases. So the health systems people will make the argument that there have to be trade-offs and payoffs to health systems, broader health systems development, rather than just simple, although not simply implemented, but rather than investing all of our resources into elimination and eradication programs. So I would say that those are the primary contributions. So methodologically, philosophically, and from a financial argument point of view, but also an ethical point of view, that if you're going to invest in elimination and eradication programs, that there needs to be some longer term benefit to the health systems that are going to affect and contribute to the health of the entire population, and not just those populations in which the diseases that are going to be eliminated and eradicated are. And that those benefits accrue to those populations over the long haul. From the health system side, I would say that it's our responsibility to develop a better metric of the contributions, of the effects, either positive or negative, of elimination and eradication efforts on health system strengthening. That our metrics in health systems are very poor, and that we're not able really to, at this point, say that there are positive and or negative effects in a reliable way. We can tell you that philosophically, we can tell you that rhetorically, and we can tell you ideologically, but we can't really tell you empirically. So I'd say that was one of the major contributions that one of the major research areas that, from an operations research area, that we need. So that's one. I mean, I think that it's important from a health systems point of view to have the contribution of all disciplines into the development of those metrics rather than only a set of disciplines. So for example, an economist might take you down one direction, an epidemiologist might take you down another direction. But social scientists, behavioral scientists, even historians might be able to give us some perspective and to be able to say, wait a minute, let's just don't get so captured in the weeds of developing the metrics that we forget about the context. So I think that's a major contribution that can be made. Sitting on many WHO committees and many other committees where these kinds of debates go on, I think, again, the issue of the contribution of return on investment for investing in elimination and eradication efforts, actually it's triple E, isn't it? Elimination and eradication efforts should include people from all disciplinary backgrounds so that that return on investment is not just in terms of dollars, but that it has, that we're able to say what the contributions are in terms of community support and trust in both economic and epidemiological ways, but also in community participation and community strengthening, and in health system strengthening. So I think that all of our disciplines contribute to that. Historians have made some very important contributions to the argument for investing in elimination and eradication programs. And have called us to account for the way that those investments have been made in the past and perhaps some of the poor uses of resources that we've had over decades. And so from a historical perspective, I think it's important for them to keep poking the tiger, you know, for them to keep saying, and social scientists and others to keep saying, but, what are we getting for this? And what are we getting in terms of a broader perspective and not just a money perspective and an epidemiological perspective?
I'm an epidemiologist at CDC, so my discipline is actually somewhat the policy, but for me more the implementation and how to mold that implementation in the field. So from our aspect, we're trying to bring our discipline to what is effective in delivering the services that lead to elimination and eradication. That includes the campaigns, but we're aware that we need to help with the fundamental health services as well, primary immunization and routine immunization, primary health care, sorry. So that we're kind of the end point. We would like to benefit from what knowledge we gain on why a community is not accepting or demanding a service versus the ones who do. And that's where we're at. We're in where the communities we have problems are, they're not engaged enough to understand that this intervention is good and will stop this problem, which is paralysis. So we need to interact better on understanding how the services are taken. We have people who are saying we should not be just giving eradication demand or saying there's a fiat for eradication, but listen to the community. Have things come up from the grassroots. My point is we need to have a little bit of a dreamer idea of this is actually a good and convince the community. But the question I brought up is not just that one, that interaction of community engagement. It's the problem of working through governments and multiple levels of governments, the traditional leadership and all that, all those layers. And how do we understand the culture of each of those to help us get to where we want to go?
My discipline is anthropology, and I think anthropologists can contribute in a variety of ways to global eradication and elimination efforts. One of the things that I would highlight is anthropologists can understand the organizational side of of elimination and eradication efforts, because achieving disease eradication requires putting the right tools and the right policies into motion, but there's always an organizational side to the background of all of that. And the organizational side is seldom studied and understood very well. And to make that connection between the tools and the means that are being used to eliminate particular diseases and the people on the ground where these interventions are happening as effective as possible, it is really helpful to understand the translational processes that occur when organizations take up particular policies, start using particular tools, and try to bring that in an effective as possible manner to local communities on the ground.
I think in a general sense it provides a kind of perspective to what's gone on in the past and the lessons that can be learned from what went on in the past. And some of those lessons lead to a kind of critical perspective saying, well, certain things are not going to work. And then other things are going to actually provide you with keys to what might work. And if you look specifically at something like malaria eradication and looking not only, I mean, a lot of the discussions about why it went wrong in the 50s and 60s, but if you look at the programs that succeeded, you can actually learn things that could be useful for planning and going ahead. So for example, the successes that were achieved in places like Taiwan indicate that it is in fact imperative that you develop surveillance systems that are reflective of both the existing infrastructure and of the epidemiology of malaria. So that, and that you continually be attentive to changes in both of those things and continually willing to adjust. So I think there are lessons of that sort that can be very specifically applied in thinking about how you plan. But I think the other thing that history provides is an understanding of place, and that all control programs, all public health measures occur in particular places that have particular histories, and that it's important to recognize the impact that those places and histories have on what's being done, and often they're ignored. I don't know if it's so much questions, but I think there's certainly projects that one could imagine. That I think that there's a lot to be learned from what's going on at the present, and that having historians embedded, if you will, in ongoing programs, like what's going on with rollback malaria, or a place like Zambia, where they have been working on malaria elimination for years now, going back into the early 2000s. But if you have historians embedded in those processes, that they're firsthand able to sort of record what's going on and to provide insights as you're going forward in time. And it's not so much that they are, well, some of it's, that there are different questions that historians ask about a particular phenomenon that's going on, but it's also the importance of having access to what's going on and being able to record what's going on so that in the future programs will learn from these programs that have hopefully been successful, and that those lessons can be applied going forward.
I've got to learn that eradicating and eliminating some of the diseases that we have put forth requires more of a multidisciplinary kind of approach. And one of the things that I've learned is how to build a team that can be able to move this forward, and build a team that is not only able to move it forward, but a team that is objective, even in the midst of shortcomings that are there in the field of eradication, and a team that is focused. So that is one thing that I think I've learned along the line. Yeah, I think as we look forth to eradicating some of the diseases that have been mentioned, listed out by WHO, and looking at the wider list, malaria and the others, we need to explore how much is the cooperation, the community involvement plays when it comes to the eradication. Because my view is we have dreamers, we have teams that goes out there and they have this dream of eradicating the various diseases. But when you go out in the community have different interests, they have different ways of looking at it, and even to some extent, the various government officers that you're working with might not look at it like it's a major public health problem to them. So the first thing that I think we need to do is to ensure that the community owns the process of the eradication, and that, how much that needs to be done and the ways in which that should be done, I think needs to be further explored, and how much that contributes to sustainability, which I think it does, also needs to be explored, and I think it's the next way forward so that we can be able to eradicate some of these conditions, some of these diseases, not just in a timely fashion, but in the most cost-effective way possible.
Okay, I am an epidemiologist and an anthropologist, and so my work, I'm involved in elimination programs, specifically river blindness elimination. So my discipline helps in mapping the areas that are affected, identifying those communities involved, and ensuring that they are mobilized, educated, and empowered to participate in the elimination of the disease that affects them. Because we are dealing in programs that affect masses, the masses cannot be brought to the hospital. You have to find them in their own communities. That presents us with a human challenge, how to ensure that how to maximize their participation in the elimination program. And so that requires parasitologists so that we can be able to demonstrate to the community that they have the disease, but also you need people with social skills. How do they convince or identify ways of involving, say, women? How do we ensure that a person who is supposed to receive the medicine comes every year to receive this medicine? And that requires different areas of social science that we can bring on board to help in the efforts towards elimination. You need also economists to be able to say that this intervention was cost effective, but this was not cost effective. How can we make it more cost effective? How can we make elimination feasible in the eyes of a donor, in the eyes of a policymaker, so they don't think that this is an expensive venture which they cannot afford? So if we can prove that elimination is affordable, then most policymakers and decision makers will be on board, and it makes it difficult, especially when they are not even public health experts. These are politicians that need to answer questions from their constituencies.
So as a health economist, we are trying to find out the amount of resources that are actually needed to accomplish this goal of global eradication. Because it's one thing to say we want to eradicate malaria or polio or whatever, and it's another thing to do the assessment of the resources that are available or that might be needed to eradicate a disease. And that is the role we are trying to play. In the meantime, we're also trying to see what are the alternative strategies that will be cost effective. If you have two competing strategies, which one is more cost effective so that we can save resources and use them in a different, in something different that might be of a greater need as well, because they're always competing ones. And as economists, we speak of opportunity cost, so we try to see which one is less has less opportunity costs, and then advise government and whoever is involved in malaria in eradication to adopt that strategy. So as economists, we are always geared towards talking about the resources that are needed to eradicate a disease, but we understand very little of the nuances that communities that are needed to engage a community so that we have sustainable disease control, elimination, or eradication, whatever word you want to use. So I think historians have a role to play to help us understand the communities, where they come from, where they are, how they look at things. Anthropologists have a role to help us understand what the communities want, who are these people. And as economists, we have the role to understand them, the communities, and also what are the priorities. So I think somehow we need to bring all these disciplines together to understand the communities that we are working with in order to have sustainable disease control, elimination, and eradication in the end.
My discipline is medicine. I'm a physician, and I am a infectious disease specialist, and I am a public health practitioner. And my interest in particular is in the delivery of large programs, the implementation of programs at scale, and the delivery of the commodities or the interventions needed to reach the objective of an elimination program, which is essentially 0 cases of the infection, be it a virus or a parasite or a bacterium, in the overall human population of the planet. And I think it's very important to have people who are involved in thinking about implementation of these programs. What people say about eradication programs is that it's a program that has to get everything right, everywhere, all the time. And achieving that kind of perfection is, in an imperfect world, is a great challenge. Well, public health practitioners need to work definitely with social scientists. We cannot achieve our goals if the communities that are the recipients of the services of these programs aren't on board with the idea and indeed aren't partners. I think we ought to be aiming to have communities actually involved in the implementation or at least the planning and execution, so that what we're doing is appropriate for them or in their eyes. The idea is that politicians like to say all politics are local. Well, I believe that all programs are local. And it's great to think on a global grand scale, but if we don't think locally about how people are engaged and involved and partners in these efforts, we won't succeed. So that's the social science piece. The historian piece is a bit more challenging. And don't get me wrong, I'm a history buff. I'm not sure I'm convinced that history repeats itself, but it certainly rhymes. I mean, there's certainly things that come about over and over that sound alike through history, and we are doomed to perhaps fail if we don't think about what happened in the past, but put them contextually in terms of the present. I think there are a lot of things that are different now than in the 60s, different in the 60s and the 1860s, and the 1760s, so it's hard to say that fighting Napoleon's war with everybody lined up and marching forward into a machine gun makes any kind of sense now. So I don't think that we can take those kinds of ideas that everything is valid that happened in the past and applies to what's going on now. That said, I really think that the experiences, for example, of the Rockefeller Foundation with their various eradication attempts, like attempt to eradicate hookworm, for example, or yellow fever, is a very interesting piece to look at, particularly if you're a group like the Gates Foundation that wants to sort of do some of the same things that a large philanthropist was interested in doing at the turn of the century. I think it's very worthwhile looking at those kinds of experiences in particular, with generating large coalitions, getting people to work together, and so forth. The last thing I'll say is, I heard a saying once, if you want to get the most out of science, you must first understand the science of human behavior. And I think that's really true. I don't think people behave all that differently now than they did 1,000 years ago in terms of relationships, power relationships, politics, and the desire to do good. And I think that's a very important element as well.
So my formal training is in social behavioral sciences, and I see that field as being somewhat in the middle between a number of different disciplines. It tends to draw on both the methods of both more traditional epidemiology, but then also psychology, anthropology, sociology, and to use that combination of methods to think about the ways in which a number of different factors at different levels are influencing people's behaviors. And so thinking about the types of topics that are often the primary subject for other disciplines, so culture, or thinking about cognitive processes, or thinking about economic factors, or thinking about various geographic or health systems factors. And so looking at topics that are part of other disciplines and from methods that are both public health or more social sciences. And I think in terms of eradication and elimination programs, the biggest contribution there is trying to think about how we can make it easier for people to adopt the strategies that we want them to be adopting, whether that be an individual daily behavior like bed net use or a one-time thing like participation in an immunization campaign. I think in public health, we often focus a lot on the effectiveness of the strategy in isolation. And then there's a lot of emphasis on persuading people to do things. I think one important contribution of social behavioral sciences is also thinking about how we can modify those strategies to make them more palatable or make them easier for people to adopt. And that might mean changes at a systems level, at a health facility level, at a community level, and not just at the level of the individual. I think one of the things that has come up a lot in this conference, and it was particularly interesting, was that people from a wide range of fields were very much wanting to understand kind of what drives funders in making their decisions, and thinking about the discourse that's currently used to be getting money to support efforts, and whether there might be some room for that to change. So do we have to sell our particular strategy as one that's going to address everything, including the kitchen sink, or can we have some different claims, and looking potentially over time at what things have been persuasive for donors, which things get funded, which things don't. So I think that's an area where everyone would be interested and would benefit. I also think that they're, similar to what I had said earlier, this area for figuring out not only how we push people to do what we want them to do, but how we can get information from them to make things easier. So I think one of the great strengths of this conference and having people from these different disciplines in the same room is that it has broken down some of the assumptions I think that people hold about other disciplines and what they do. And it's been really interesting to watch that happening in the room as people are talking and realizing that some of these fields are thinking about elimination and eradication much more critically than others might have assumed, or thinking, for example, that more of the humanities and social sciences people have more pragmatic and practical interest than some of the practitioners were assuming. And so just by nature of getting people in one room, I think we're doing some important work by breaking down some of those assumptions, and then also just helping people to learn a little bit of each other's language and how we can translate in these conversations with people.
Well, I think based on the discussions that we've had in our symposium today, it would be very useful looking across the existing disease-specific elimination and eradication programs to have a multidisciplinary approach that relates to assessing the impact of these programs on the health systems and to see how to maximize the positive benefits of the interaction between elimination eradication programs and the health system, and to minimize the negative benefits. This is a theme that was a recurrent theme today, and I think there would be a value not only of having this multidisciplinary approach, but also to look across targeted diseases to see what similarities and differences there might be.
Well, I work in public health. I'm a public health practitioner, and we work primarily on strengthening the routine immunization system. And by strengthening the routine immunization system, we're actually contributing to the elimination and eradication of disease, because that's the platform or the cornerstone of the health system. If you want to sustain the gains from measles campaigns or polio campaigns, you have to have a strong routine immunization system. Otherwise, you'll be forever in the mass campaign mode, and that alone isn't going to actually achieve the objectives. We oftentimes say that there are all of these unintended negative consequences of elimination and eradication initiatives, and I believe there are lots of them. But in fact, a lot of them are predictable, because we've seen it again and again with each time there's a new elimination or eradication initiative. And studies have shown that there are negative consequences and there could be positive consequences. These things don't happen automatically. You have to deliberately make sure that the positive takes place and deliberately mitigate against the negative taking place. And this has been the result of studies done by WHO, London School of Hygiene, and others. So I think the research question that needs to be asked is, what would it take for elimination and eradication strategies to actually have intended positive collateral benefits? And similarly, the research could ask, why doesn't it happen?
I can't speak for a discipline, but as this historian, I don't believe that eradication is a reasonable goal. It takes up too many resources, it's top down, and it forces all countries to come on board whether they want to or not and subordinate their priorities to the priorities from on top. I believe that's bad for the countries, and it's a price that's too high to pay. Elimination campaigns, again, if countries want it. I mean, the whole key is, do countries want the elimination? Is this something that they're asking for? And then the global community with funds can help them achieve that goal. But if it's a top-down elimination campaign, then it's just like an eradication campaign by subordinating the country priorities to somebody else's priorities, except they're not going to get to the very last case. They're just doing it on a more limited basis. I don't think those are two good goals. And one of the troubles with this particular conference was it seems that that was the idea. We were all supposed to agree to the basic fundamental good, eradication, elimination, and how could we make it stronger and better. But the fact of the matter is, I think there's a good case for being opposed, certainly to eradication, and limiting elimination to reflecting country views. Education is vital to get people on board for health in general. And I think what's been assumed was the education has to be done from the top to the countries and the communities. And what the donors and bilateral donors, I mean the philanthropic donors like Gates, or what the bilateral donors like the United States or Britain or Sweden or what have you, it's assumed that they want what they want, and then you just have to bow to it. And I think what we need to do is some research on the question of, can we affect educating them to stop being so short-termed, so much concerned about a beginning, a middle, and an end within a short period of time. One of our people said they would never dream of doing maternal and child neonatal health because it's gone over a very long period of 20 or 30 years. But in fact, that's exactly what's happening with polio. And many of the other eradication campaigns, despite their limited time frames, are going to take very long periods of time. And if you can sell that, then why can't you sell something as fundamental as maternal health and neonatal care? And we haven't been trying to do that because we've gone along, public health in general has gone along with, well, of course that's what they want. And I think we can stop doing that, and we can say social scientists and historians and policymakers can come together and say, hey, why don't we research this? Why don't we find out where the weak point is in their commitment to these short-term things, and find out strategies and plan strategies to try to move the ball for these people. And it's happening to some extent. Gates apparently has moved from, you know, vaccines and only vaccines, and nothing to do with routine immunization, to at least taking that into consideration to a greater extent than he did before. And we have to have him do that even more than that, as well as many of the other donors.
My discipline as a social scientist, anthropologist, I think part of what we have to contribute is using different methods to study from different perspectives, study the policy making process, study the implementation process, study the community perspective, and how these differ and how they're the same, and how to put those perspectives together. One area I think that needs more study is the community perspective, to really understand what are the community priorities to begin with, and how the community responds to the different eradication elimination programs, what the meaning is, how they're perceived in the community, and in addition to other studies, but also how to communicate the findings of research, whether it's at community level or policy level, in a way that's meaningful for both the social scientists, historians, and practitioners and policymakers. I think we really need to find ways to translate our research and find the best way, the best terminology for presenting it, and the best media for how do we reach people with the results, with the outcomes and findings, and get the response to those, to research, and then find ways to develop joint and collaborative studies.
So my discipline is anthropology, medical anthropology, and particularly I take a view that is called cultural ecological, and I've been very interested in historical issues of the relationship between improved health and economic development. So what I have a lot in common with historians, but on the other hand, I think I'm asking larger system questions about the relationship between wealth and health. And what we can bring to disease elimination and eradication programs are two things. One of them as people who focus on culture, the ideas, beliefs, values, everyday practices of different societies, we can better understand them both on the side of the people in low and middle income countries who we're partnering with, and help to describe and understand and analyze the cultural beliefs and values of the public health community itself. So every global health intervention is a cross-cultural interaction. So one of the things that we can bring is not only some understanding about the local people, but also some reflexive, more humble understanding of our own culture, that is the global health communities, the people from the developed world, ideas, assumptions, and issues of power in those relationships. I think that it's very important for anthropologists who often have a critical eye to emphasize constructive criticism. So looking in history, using history or social science aimed at understanding disease elimination and eradication programs, I think anthropologists can be instrumental in helping those cross-cultural communication issues that come up. But I also think that the anthropologists and historians can take an outsider's view of these major world efforts. Some of the largest cooperative efforts in world history, smallpox eradication, or any of the issues in the Millennium Development Goals, so that we can help humans achieve these wonderful goals, these lofty goals and targets. Yes, I think that there are a number of common areas, and in some ways the conference itself is designed to get the public health practitioners to articulate what are the issues, the social, cultural, organizational issues that they would like to know more about. And the conference itself allowed us to talk openly, partly because we didn't have any funders there, or the people can talk more openly about problems and failures. But if you learn a lot from failures in the past. So if I'm going to say, let's look at the disease eradication programs, one victory and 10 losses. I'm not counting the veterinary disease, rinderpest. And we have already decided that we have single disease eradication programs working, and probably more in the future being designed. Then we should analyze those programs about what worked and what didn't work. And I think this idea of predictable unintended consequences of our actions are something that is worth exploring. The main issue has been if single disease elimination or eradication programs can be used to strengthen local health systems or strengthen things like routine immunization programs. And I think that this has not been explored thoroughly in particular contexts. So I think it's easier to analyze failures using the past because you don't necessarily get people's egos involved that much. And I think it's important to recognize that our colleagues who are doing disease elimination and eradication are making history, but they don't necessarily get to write the history. So I think, for example, historical case studies of a certain place over time with different disease eradication programs, sleeping sickness, malaria, polio, etc., and looking at what the dynamics were, what worked and what didn't work would be a good project. But I think that there's a lot to be said about the strengthening of local health systems through these new single disease efforts. So the Global Fund has emphasized malaria, tuberculosis, and AIDS, and we have more money in this area of global health than we've ever had before. So I think it's very important to make these efforts not only targeted at the single diseases, but more importantly to have sustainable benefits in the health systems for the long run. So those are the two ideas. One of them is focusing on a certain area with a number of different programs, or cross-nationally or cross-programs look at what are what were called predictable unintended consequences.
The preceding program is copyrighted by Emory University.